For the AP projection of the foot, place the patient in the supine or seated position with the affected limb fully extended. Then, adjust the ankle joint to the true anatomic position. Here, the foot should be pointing straight up. Flex the ankle and foot enough to place the long axis of the foot in a vertical position. Direct the central ray perpendicular through the ankle joint at a point midway between the malleoli. Collimation should be 1 inch on the sides of the ankle and approximately 8 inches lengthwise to include the heel. Typically, a 10 by 12 cassette placed portrait is used or sufficient for this exam. The resulting image shows a true AP projection of the ankle joint, the distal ends of the tibia and fibula, and the proximal portion of the talus. Also, when evaluating this image, notice how the talus slightly overlaps the distal fibula. Also take note to the tibio-talar joint space. As we begin to position the patient for the more piece view, grasp the distal femur area with one hand and the foot with the other. Assist the patient by internally rotating the entire leg and foot together 15 to 20 degrees until the intermalleolar plane is parallel with the IR. Be sure to dorsiflex the foot so the plantar surface of the foot is placed at a right angle to the leg. We will direct the central ray perpendicular, entering the ankle joint midway through the malleoli. For the Mortise view, it is essential that we assist the patient by internally rotating the entire leg and foot together. This will ensure that we will actually see an entire ankle Mortise view or joint space in profile. The 3 sides of the Mortise joint must be visualized, as seen in image A. Notice in image B, not all 3 sides are visualized clearly. This is a result of improper internal rotation of just the foot and not the entire leg, as demonstrated by image B. Compare the two. You are now ready to move on to the medial lateral projection. Have the patient lay supine, turn toward the affected side until the ankle is lateral. Place the long axis of the IR parallel with the long axis of the patient's leg and center to the ankle joint. Ensure that the lateral surface of the foot is in contact with the IR. Then, dorsiflex the foot and adjust it in a true lateral position. Dorsiflexion is required to prevent the lateral rotation of the ankle. You may now direct the central ray perpendicular to the ankle joint, entering at the medial malleolus. Collimation should be the same, 1 inch on the sides of the ankle and 8 inches lengthwise, but be sure to include the heel and the 5th metatarsal base. The resulting image shows a true lateral projection of the lower third of the tibia and fibula, the ankle joint, and the tarsals, including the base of the 5th metatarsal. Be sure that the tibio-talar joint is well visualized with the medial and lateral talar domes superimposed. Also, be sure that the 5th metatarsal is seen so you can check for a Jones fracture.